Assalamualaikum and a good day to everyone. Thank you, Prof. May and the organizer for having me here. I will be presenting on the tips for beginner. So pretty much this topic does not have any standard textbook to be used as a reference, but most of the words that I'm going to share here are mainly gathered from my mentors, my personal experience, as well as tips from other surgeons, which was published in a few articles. Now, again, I always like to guide myself by categorizing the details that I'm going to share. So firstly, I will touch on the personal attitude of the training itself and self-preparation to go through the journey. Then comes to your physical preparation and so on, including the surgical training, as well as having a good track record of your surgery. Now, let's start with the mental preparation. So nothing surprising when we say mentally prepared, you have to make sure that this is what you want to do in years to come. It involves the long hours of training, long surgery compared to the standard cataract cases, potentially long-term relationship with your patient. You also have to deal with this discrepancy between the functional outcome as well as the anatomical outcome, whereby functional outcome may not be as good as the anatomical outcome. You have to deal with this patient's frustration if things does not go well. And again, it is of course not always simple. It can be as complex as a combined cases with your other colleague or even redo cases. Now, because it will take a lot of your time and effort to go through the training, support and understanding from your immediate family members are very, very important. Apart from preparing yourself internally, it's good to get into the right group of people with the same interests, locally and internationally. So you can join as a junior member of any retinal society. I found there's a lot of forum ongoing on the internet as well among the fellows. So those are the nice group to be in to get some support. Again, I think one of the most important part to start with is the stress management. It is not only important for yourself, but most importantly for the people around you. So remember that the success of a surgery rely highly on the group of people that you work with, because the surgery itself can be difficult enough, and to add on the stress that you can't control, it will just make the situation a lot more worse. Now, before I go into more detail on the physical aspect of preparation, just allow me to highlight this one important issues on our nature of our work. So one important aspect of being an eye doctor, especially a retinal surgeon in particular, is the potential work hazard that we are exposing ourselves. So I'm very, very sure everyone knew about this, but to be able to incorporate it as part of our practice definitely require us to sort of bring that issue into our conscious mind. So it is not natural to keep our natural posture if you're actually focusing on something, especially when you're doing a very long surgery. A survey by the American Academy of Ophthalmology in 2005 have clearly showed that majority of our eye surgeons actually suffer from some form of musculoskeletal disorders, and very small proportion of us actually do not have any symptoms. This is very much common among us. Now, before we start with surgery in particular, always start with checking your surroundings. Apart from positioning yourself, importantly, start with positioning your patient. So that is step number one, so that you can comfortably position yourself in relation to the patient. So just to highlight the importance of putting the patient at the edge of the bed so that you will not stoop forward while doing the surgery. And it is also important to bring down the table to at least your comfortable level, which allows your hand to be in this 90-degree position rather in a very much flex posturing for the hand. And at the same time, once you get the patient positioned well, then you start to position yourself, adjust the tilt of the microscope so that you don't have to stoop forward or stress your neck. And again, adjust the IPD and also the power that you're going to use. Don't forget, also choose a very comfortable stool, which can also lock safely. Now, this is one of the probably not the best position of microscope, the eyepiece, this is just makes you extend your neck during the surgery. And the best position would be, something that will keep you straight upright and naturally look down. Now, apart from that, probably it will be a lot more less an issue if you're able to use a heat-up viewing system, which is the Ingenuity system that we don't offer at the moment. And particularly in long surgery, I actually love to use a cannula. Occasionally, we can actually free our hands. Remember that strain is felt more in the hand at which we don't move much, which is the left hand most of the time if you're right-handed, whereby we actually hold the light pipe steadily, not moving so much with your left hand. So compared to your right hand, which is the active hand, the strain is, you don't really feel that much of strain. Don't forget to take some micro breaks, stretch yourself in between your surgeries. And again, the importance to have a very nice stool. I always prefer the round stool with a nice armrest to put my elbow down. Some people prefer to have what we call a wrist rest, but I prefer to have the elbow rest. So I have my flexible, I'll be more flexible on my wrist. And at the same time, what is also important is the stool has to be very much stable with a proper brake system. I always try to avoid the big rectangular kind of stool because I found it gives me a bit of this sciatic pain if you have to go through a long surgery. So I suppose you have to choose what is the best tool for you and make sure it is comfortable for you to go through the long surgery. Now, lastly, even if you are not scrubbing, start to train your ears to correlate with the functionality of the machine. So that means, try to accustom yourself on how does a high vacuum sounds like, how does a high cut rate sounds like, high aspiration rate, when there's an occlusion, how does it sounds like, all those actually as an observer or a trainee, you can actually learn to do that even before you start doing your surgery. Now, not to forget, in other practices whereby, when you use the indirect ophthalmoscope, doing your indirect ophthalmoscope in a standing position, will make your neck flex down. It can be very painful. You have to do many patients. And probably the best position to get yourself in a natural position is to have yourself sitting and be at the same level with the patient. So that your neck will be in a natural position. Now, not to forget the common ones, which is a slit lamp. Again, try to be in upright position. There's a nice quote described by the it's not a quote actually, it's actually an advice from Dr. Dalwani, which I found in one of the written article. If let's say you can't really position the patient in the best comfortable position for the patient, it is actually best to think that it's better for the patient to be uncomfortable for 2 minutes rather than you have to develop the cervical disc disease. Sometimes you just have to sacrifice some part of the comfort level for the patient so that you can actually continue to examine the patient years to come, because the patient will just be uncomfortable for the 2 or 3 minutes when you're examining them at the slit lamp. Now, again, to highlight, I think I love to do cannula buckle nowadays. I have stopped doing the traditional buckle using the indirect ophthalmoscope. Cannula buckle just help to reduce the strain on the neck for the long hours surgery. Now, let's look into the knowledge part of the training. So fellowship is just the beginning. Once you become, I think in any field, you need to have this mindset of continuous learning, so it never ends basically. So although we are doing surgical retinal diseases, it is also good to have a strong foundation in medical retinal cases. So read about all those medical retinal diseases, especially the common ones. Familiarize yourself with the basic OCT readings, getting to know the updates of studies as well as the differential of some other retinal vascular diseases. So at least we are not only able to treat the common ones, but also able to identify when there are non-atypical features and refer those patients to the more expert medical retinal colleague. Now, some candidate may not enjoy writing papers, but I found that either writing or supervising publications can actually help us to update ourselves continuously. And don't forget, you also need to develop the critical thinking, and writing papers actually, helps to sort of encourage the critical thinking in the retinal field. At the same time, remember you have to improve your CV in case you need to apply for your fellowship training overseas or at the centers. And because you're actually competing with other candidates from other parts of the world, so your CV has to be outstanding. Now, again, not to forget good sound knowledge of your basic surgical tools. This is very important. It's not only about the mechanical aspect of the system, but also how it works. What are the different effects between laser and cryos? What is the microscopic, or what we call the natural process of those healing? Get to know your microscope well, the setup, especially learn about your endotamponade, indication, and which one is best for your patient. Learn to individualize the tamponade type according to patient and diseases. Also get to know the viewing system. There's many types of viewing system that we have in the market at the moment. You have the biome, the ReSight, the lenses, the handheld lenses, as well as the office system. Now, come to the most exciting part, the surgical training. Well, it starts preoperatively. Have your diagnosis right, as perfect as possible. For example, in case of vitreomacular retraction, you would think, is this a real VMT? Is this significant vitreomacular retraction? Does the anatomical changes reflect the vision? Does it correlate well? What is the prognosis of the case? With or without surgery? And if, let's say, you have a hole, you might want to think, is this a true hole, or is this a pseudo hole? All about the decision making of whether the patient really needs surgery or not. Now, another challenging part during training is actually to deal with expectations, the patient expectations. So this involves a good communication skill, learn the body language, and I find it very important in our society is to get the caretaker involved during the counseling, and also about talking about the post-op care, the post-op prognosis, the expectation after surgery. So I always try to get the caretaker involved, as much as we can. If they're busy, they're not available, we go to the extent of calling the kids, so that, especially when they're old, we call the kids so that the family understand what the patient is going to go through and give their best support for the patient. And it's also very important, not only the family member, the patient itself, has to truly understand what they're going to go through. It can be quite tedious at times. We strongly recommend that fellows spend time to observe on how the senior surgeon would actually talk to the patients, how they, with giving them a realistic expectation. Now, lastly is the preparation before surgery, whether the patient needs an anti-VEGF before, especially in advanced diabetic eye diseases cases. What are the instruments that you have to order? What are the things that you have to prepare before the surgery? So those are the important aspects of the fellowship training. Now, then it comes to the surgical hands-on training. We usually start as an assistant. Now, this part is very important even before you become the assistant. To be a good assistant, you have to be a good observer to start with. So even though, let's say, you're actually a runner in the OT, you're not actually scrubbing, even to be an assistant, be a good observer, all right? Watch how the surgeon do the surgery, observe in detail how the first assistant assists the surgeon, to know the do's and don'ts. And then again, see how the second assistant, or actually the scrub nurse, assists the doctors. So at least you know what to do and what to expect. And when you are ready, of course, you start. For me, I always advocate the trainee to become the second assistant, to be in a position of the scrub nurse. The reason being is because you get to use, you get to know the instruments that you're using better. You know how to connect tubings. You know the machine well, because occasionally when you are a surgeon, you might need to troubleshoot the machine yourself for simple faulty events in the future. So it's good to get to know your instruments well as the machines. Now, once you have successfully done that part of the job, again, don't forget, even at that position, closely observe how the first assistant do their job. All right. And then slowly, once you're ready to upgrade yourself, you know what to do and what to expect. All right. And try to understand each steps that the surgeon took and the reason behind this decision that they made. Okay. Now, how do we start as a surgeon itself? I would highly suggest training. Now, you have all the simulation training system, right? At least I know that we have here in Malaysia is the IC system. I think it belongs to the Ministry of Health, which is actually being kept in the hospital Kuala Lumpur at the moment, General Hospital. It is not much about for you to be able to simulate the surgery, but more of to improve your dexterity of your hands, especially the non-dominant hand. Because you have to try as much as you can to make both hands perfectly functional. So the system, I know the IC system helps to train the right hand and at the same time also train your left hand. Now, being a VR surgeon, you have to get used to the phaco from superior. You try not to change your position from temporal to superior if you have to do combined cases. You might take some time to familiarize with the navigation inside the eye, because you have to remember you have the invert in place when you become a surgeon. So your navigation of your microscope, moving right and left, is more or less in a reverse manner compared to your anterior segment surgery. So usually trainee will need some time to be familiarized with the surgical navigation inside the eye. Now, always learn to plan. I think this is the most important part. During training, even when you are now a surgeon, the most important part is to plan your surgery. You have to imagine what you're going to do after this and this. What are the best steps that you should take to complete the surgery without having much of complication. And stepwise training, I would say that start with a simple cases, pseudophakic eyes, probably vitreous hemorrhage with a complete posterior vitreous detachment, and slowly move yourself to phakic eyes and slowly move to more complex cases. Especially what is important is to know the do's and don'ts for every single type of surgery. And most important part is actually to learn how not to complicate the surgery. Keep the surgery as simple as you can and stick to the main primary objective. For example, dealing with vitreous hemorrhage, probably you do not want to trim the vitreous too close to the retina, because usually sometimes the view of the peripheral retina is not going to be extremely good when there is a layer of blood clot nearby to the retina. So we don't want to create a tear in such a situation. So, always keep to your main objective when you do a surgery. Another example, if you do TRD cases, traction retinal detachment cases, try not to convert the TRD into an RRD by creating a tear. So always know when to limit the manipulation safely inside the eye. Now, this is also a very, very important step. Logbook is not only to record the number of cases that you have done, but actually the most important part is to follow them up, observe the patient 3 months, 6 months, and up to 1 year, if possible, and look at the success rate of those surgeries compared to the real world data of other surgeons. So you know actually where you are compared to others. Best to have these everything recorded continuously rather than keeping it to the end of the training. There are many tools at the moment, but personally, I prefer a tool that I can use on my mobile phone and also allow me to edit the input from time to time, which I found Kobo Toolbox is one of the best way to collect and compile the data. I'm sure there are a lot more other apps available nowadays, but what is important is to have a continuous update of your logbook. Best of luck to everyone, and thank you.